Hello and welcome to this sixth webinar, and this time we're moving away from cardiology. We're going we're going to delve into endocrinology instead and look at the function of the thyroid gland and the clinical correlates associated therewith. And then the clinical correlates will encompass some year 3 material and a bit of year 4 material, in that we're looking at the function of the thyroid gland during pregnancy. So first and foremost, let's actually look at the synthesis of thyroxine, the main hormone in the thyroid gland. Okay, so let me just, okay. All right, so Shelley?
Yep.
Okay, going back, so about the histology of the thyroid gland, how is it arranged, the histology?
So they're testing me. I hate histology. So you've got follicles and.
Good. So let's start with the follicle. Okay, what is the follicle made of?
They are.
So I'm just drawing one out, and let's see if it comes back to you. Do you remember that they're circular structures?
They're circulars with a cuboidal epithelium surrounding them.
Oh, very good. What's in the middle?
Colloid?
Colloid. Very good. Yeah, see, you still remember. Good, colloid, okay. So we've got follicular cells with colloid in the middle, and we've got blood vessels running on the other side, yeah?
Mm-hmm.
Okay, we call this the apical membrane, and we call this the basolateral membrane, yeah?
Uh-huh.
Okay, so what large atom does the thyroid gland need in order to synthesize thyroxine? Worldwide, there is a deficiency of this
Iodine.
Iodine, good. So the first question is, how does the thyroid gland actually sequestrate iodine into its cells, yeah? Because iodine, it has to actually extract all the iodine from the blood by means of some sort of active transport mechanism, yeah?
Yeah.
So what it does is, it uses this interesting little channel called the NIS, okay? The NIS, which is simply a sodium iodine symporter, NIS, yeah?
Yep.
And its passive transport of sodium and iodide into this into the follicular cell. So because the concentration of sodium outside the cell is significantly higher than that inside the cell, and there is a lot of sodium running around outside the cell, the electrochemical gradient of sodium pulls iodine with it and concentrates it inside the cell.
Mm-hmm.
Okay, so that's what it's for. Okay, so when you have iodine being concentrated inside the cells, iodine just travels into the colloid by means of diffusion. Okay.
Yep.
So what you're effectively doing is you have iodide ions swimming around in colloid. Okay.
Mm-hmm.
Now, meanwhile, what happens is that, going back to first year, when a cell synthesizes a protein, this protein synthesizes in the ribosome, then it moves to the rough endoplasmic reticulum, moves to the Golgi apparatus, and then gets secreted by means of exocytosis, yeah?
Mm-hmm.
Yeah. And the protein that's released by means of exocytosis is a protein called what?
The protein is created after the iodine has been.
So it's a separate process, okay? So it's a separate process. This process is about iodine being sequestrated into the colloid, but there's a separate process which also occurs where a protein gets thrown into the colloid as well. And this protein is called thyroglobulin. Thyroglobulin, good. And thyroglobulin is just like any other protein, and it contains the amino acid tyrosine, yeah?
Yep.
Okay, it contains amino acid tyrosine. So what eventuates is that the tyrosine, thyroglobulin gets released into the colloid. Yeah.
Yep.
Now, do you remember how I mentioned it was exocytosis, but that was the means by which thyroglobulin was thrown into the colloid?
Mm-hmm.
If you actually look at the secretory vesicle, which actually releases this thyroglobulin, you find something quite interesting. You'll find that if it's a phospholipid bilayer, yeah?
Yep.
Okay. On the interior, and the phospholipid bilayer will contain membrane proteins.
Yep.
Interestingly enough, there is an enzyme which is situated on the interior of this vesicle, yeah?
Mm-hmm.
It's called thyroid peroxidase.
Right.
And in which disease do you find antibodies to this protein?
Antibodies to thyroid peroxidase.
Yeah.
Because that would be destroying it.
Yeah. You're inhibiting the function of the thyroid by inhibiting thyroid peroxidase, correct?
Yeah.
So, which disease do you think would cause it?
You're inhibiting thyroid function. So is it Hashimoto's?
Yep. Hashimoto's thyroiditis has antibodies against thyroid peroxidase. Good.
Yeah.
Can you give me 2 drugs that inhibit this particular enzyme?
No idea.
Do you remember carbimazole by any chance?
Yep.
Carbimazole, propylthiouracil. These are antithyroid drugs.
Oh, okay. Sure. So that's how they act.
Yeah, that's how they act. They act on thyroid peroxidase. Okay. So imagine if this was your secretory vesicle and we're still inside the cell. So I'm going to buff up the cell like so. And then the secretory vesicle will approach this membrane, and then the membrane will the vesicular membrane will incorporate onto the cell membrane here, yeah?
Mm-hmm.
In doing so, when it does that, it exposes the thyroid peroxidase to the colloid. Doesn't it?
Yep.
So when you secrete the thyroglobulin, you have thyroid peroxidase being expressed over here.
Mm-hmm.
Now, what that does is, by means of, it causes iodide to react with hydrogen peroxide. Okay?
Mm-hmm.
And when it reacts with hydrogen peroxide, it produces iodine radicals, iodine atoms. You just take the electron off the iodine. Yeah? This is very, very reactive, yeah?
Mm-hmm.
So that this iodine atom, okay, it's been oxidized by a reaction catalyzed by thyroid peroxidase. The iodine will react with the tyrosine residues in the thyroglobulin, yeah?
Mm-hmm.
So imagine if this is your thyroglobulin and you have tyrosine residues bouncing off the thyroglobulin. So this is your thyroglobulin and you've got tyrosine residues maybe here and here and here. And to this tyrosine, iodine binds to it.
Yep.
Yeah. Often it's two atoms. It can be 1, it can be 2, it could be either. Yeah.
Yep.
Now, if this is this is your tyrosine, and your tyrosine has just been iodinated. Yeah.
Mm-hmm.
So we call this the organification of iodine.
Mm-hmm.
Iodine has been incorporated into an organic compound. What happens afterwards is that, and this is also catalyzed by thyroid peroxidase, the protein folds in on itself, and you get multiple of these tyrosine residues basically bumping into one another and then annealing, bonding to one another. So what eventuates is that you get a little stub here, and you get an extension of one of the tyrosine residues to get something looking like this. Yeah?
Yep.
And this resembles thyroxine.
Mm.
That's a thyroxine residue. With me so far?
Yeah.
Now, so your thyroglobulin molecule has been modified. So you've got thyroxine residues off your thyroglobulin molecule, yeah?
Mm-hmm.
Then what happens is this over here, that's just going to go into here and here.
Yep.
Okay, so there's going to be endocytosis. So this secretory, the protein will be endocytosed, and it'll form a vesicle. Yeah, you'll have a vesicle here full of your thyroglobulin with its thyroxine residues sticking out the side of it. Yeah.
Yep.
Then this vesicle will fuse with the lysosome. Yeah. Because we need to break up the thyroglobulin to release the thyroxine. Yeah.
Yep.
Then, so this fuses with the lysosome. So this will fuse with the lysosome, and you form a secondary vesicle whereby you then cleave off. You chop up the thyroglobulin because the lysosome contains proteases, and then you release all your little thyroxine molecules. Yeah.
Yep.
So not just thyroxine. Yeah. And your thyroxine, keep in mind, most of it will contain 4 iodine atoms. That's tetraiodothyronine. This is T4. You could have this is T3.
Yep.
Everything all right?
Yep. I'm just grabbing a blanket.
Yeah. Can you see what I'm drawing?
Yeah.
Okay, good. And then that is diiodothyronine, DIT, and this is monoiodothyronine. But no one gives a damn about these two. These don't work. These are inactive, yeah?
Yep.
So now, these are basically secreted into the circulation by exocytosis. Okay? So you can see that the thyroglobulin has done a 360-degree turn. Got thyroglobulin being secreted out here, being reuptaken, then chopped up by a lysosome, and then the thyroxine secreted, sorry. Yeah?
Yep.
So that's how thyroxine is synthesized, yeah?
Yep.
Okay, so that's the synthesis of thyroxine. So now, thyroxine, when it's synthesized, about 90% of it that is secreted is T4, about 10% of it is T3. So it's mostly T4. Of these two, which is more biologically active?
T3.
Good. So what happens is, so now let's talk about the transport of thyroxine, yeah? Okay, so how is thyroxine transported around the body? Keep in mind that thyroxine is lipid soluble. That's why it has nuclear receptors in its cells as opposed to cytoplasmic, as opposed to membrane receptors. Thyroxine is not particularly soluble in water.
So it probably needs a binding protein.
Good. And which binding protein does it use?
Thyroid hormone binding proteins? I don't know.
Close. Thyroid binding globulin.
Okay.
Thyroid binding globulin. So not thyroid globulin, thyroid binding globulin. And it also uses albumin. Albumin is also used as a carrier protein as well.
Yeah.
Okay. Now, therefore, because there's so much thyroid, most of the thyroxine, about 99.98% of the thyroxine is bound to protein, yeah? So you could imagine that the half-life of this of this hormone would be pretty damn high. Yeah? So the half-life is about 8 days for T4 and about 1 day for T3. Okay? All right. The question is, if this is a much more biologically active hormone, how do peripheral tissues use T4? Well, let's actually look at the structure of T4 and T3. Hold on, I'm simplifying the picture, by the way. Okay. So if this is the backbone, okay, you can think of T4 as looking like this, and T3 as looking like this. Okay. Yep. And nothing here. Okay. So this is T4 and T3. There's an enzyme which causes the cleavage of one of the iodine atoms. Yeah. Yeah.
Yeah.
And this enzyme is called 5' 3' deiodinase. Deiodinase. And you can see why, because iodinase, yeah, it's taking out deiodinase. You're taking out one of the iodine atoms.
Yep.
Now, there are two types. Type 1 is found in a number of tissues, liver, kidney, and the thyroid gland. Type 2, importantly, is found in the pituitary.
Yep.
The pituitary gland. Now, moving back. Okay. Now, this is a little important because there's a particular type of disease. There's a particular type of not disease, state called the thyroid syndrome. And the way it works is, if you are severely ill, I'm talking if you're septic, if you've had massive caloric restriction, if you're under severe physiological stress, okay, for some reason the thyroid, this enzyme, the type 1 enzyme, is inhibited. Okay, so what do you expect to occur to T3, T4, and TSH? The TSH, thyroid stimulating hormone, T4 and T3. What do you expect to occur to T3 given that this deiodinase is being inhibited?
So we were discussing this before. The T3 drops.
Yeah, T3
the
drops.
Stays the same, but it's a type 2 that's up in the pituitary, so the TSH doesn't increase.
Exactly.
The T4 doesn't increase either.
Yeah. T4 circulates, and T4 can be converted to T3 by either type 1 or type 2. So the peripheral tissues won't be synthesizing much T3, but you have normal levels of T4. What happens afterwards is that T4 will still be converted to T3 inside the pituitary. So the pituitary still thinks that you've got normal amounts of thyroxine in your body. You've got normal amounts of T3 in your body. Yeah, because the pituitary can convert your T4, the peripheral tissues can't. So the pituitary doesn't moderate its, the pituitary doesn't change its production of TSH and T4. Yeah?
Yep.
So that's the clinical correlate associated therewith. Okay. Now, so that's about we've just talked about the synthesis and the transport of thyroid hormone. Now comes the important bit. What does thyroid hormone actually do? So what sort of function does thyroid hormone do in general?
So it's got effects on heart rate and cardiac output, basal metabolic rate.
Yeah, good. The metabolic rate. That basically sums up the function of thyroxine. Yeah, good. Increase the metabolism. Yeah, and it does it by a variety of means. Yeah. Firstly, it increases the basal metabolic rate. Okay, which is why if you're hyperthyroid, you become a bit. You get a heat intolerance because your body temperature starts to elevate a bit. Okay, so your basal metabolic rate increases for a number of reasons. Okay, so let's talk about the metabolic effects that thyroxine has on the metabolism of glucose, the metabolism of protein, and the metabolism of lipid. Okay, so glucose. Okay, thyroxine increase the gluconeogenesis. Do you remember gluconeogenesis?
Yep.
Yep. And in which organ does gluconeogenesis occur?
Freudian slip, the liver.
Yeah, good, in the liver. Gluconeogenesis occurs in the liver. But interestingly enough, it doesn't lead to diabetes because, yes, thyroxine increases gluconeogenesis, but it doesn't impair the sensitivity of peripheral tissues to insulin. So you're not insulin resistant. So your pancreas will appropriately increase its output of insulin. So you still have normal glucose levels. What
if you've already got an impaired glucose tolerance and you suddenly become
hyperthyroid? Very good question. My supposition, my guess would be that it would exacerbate the diabetes, but I don't have any evidence to support my theory. This is a theory.
Yep.
Okay, but very good question. I like it. Now, what does it do with protein? Interestingly enough, thyroxine causes catabolism of protein in muscle. Okay, so it increases catabolism, breakdown of protein. But interestingly enough, it also increases the synthesis of protein as well. So you can say that there's an increased turnover of protein. That's a good way of thinking about it, yeah? So it increases the production of protein, it increases the breakdown of protein, but the net effect is actually breakdown of protein, which is why when you become hyperthyroid, you tend to lose muscle mass.
Yep.
Okay? The third thing is lipid. Thyroid hormone causes lipolysis, which we all know, yeah? It also increases lipogenesis, funnily enough. In simple terms. Again, it increases the turnover of lipid, yeah? So if thyroxine were to act on adipose tissue, it actually causes the adipose tissue to actually degrade its triacylglycerols and release fatty acids, yeah. But it also causes lipogenesis as well in the liver, I believe, not sure. But it increases the turnover of lipid. But the bias, again, is towards degradation of lipid, especially at high T3 levels. So can you see the general trend is degradation and production of material. In fact, back to protein, actually, I'll get back to that later. I want to see if you can get it when we talk about hyperthyroidism. Okay. The other thing is, the fourth thing it does is that thyroxine actually causes ions to move in useless directions, okay? So if you have a cell, the cell is highly permeable to potassium, reasonably permeable to sodium. There's a lot of sodium here and a lot of potassium inside the cell, yeah? What would you occur, now, if I were to upregulate the activity of the sodium-potassium path, yeah? You wouldn't expect much of a change in concentration to these two species, yeah? Because if you increase the activity of the pump, okay, you chuck extra sodium out more than you're supposed to, some of the sodium will just flow back in again. And if you chuck more potassium out than you're supposed to, if you stuff more potassium in than you're supposed to, potassium will just sneak out, won't it?
Yeah.
So all you're doing is you're causing these ions to move in a circular direction.
Yep.
Okay, so that's great for the production of heat, but it does no work whatsoever, does it?
Yes.
Okay, so that's another way by which thyroxine increases the basal metabolic rate. It just causes useless chemical reactions, basically. Useless movement of ions that does nothing for anyone except produce heat.
Yep.
Okay, all right. Now you mentioned that thyroxine increases the heart rate. It also increases cardiac output. Why does it do that? You're right, but why?
Well, it'd be increasing cardiac output by increasing heart rate.
But why? That's one reason why.
Does it have an effect on stroke volume as well?
Why does it have an effect on stroke volume?
No, I said does it have an effect? I'm not sure.
Oh, it does.
I don't know.
There's a few reasons for it. Okay. In fact, I actually asked a very similar question. Have you heard of the practice exam that MUMAS ran a couple of weeks ago? Did you hear about it?
No.
Okay. In fact, this question. So I wrote this question that asked about.
I heard it was being developed. Yeah.
Yeah, there was a question on. Well, it wasn't thyrotoxicosis. It was on beriberi, but it was a similar. Pathophysiology.
Okay.
But yeah, okay. So basically, what thyroxine does is a few things. Thyroxine increases peripheral metabolism. Okay. Because remember, it increases metabolic rate.
Yep.
Okay. What does that do to the surrounding capillaries? Sorry, the surrounding arterioles. Sorry. What does it do to the arterioles? If I mention the word active hyperemia, would that ring a bell to you?
you get vasodilation at surface
It-
capillaries and things to
or
try
not,
and reduce body heat.
not to reduce body heat, but to provide the oxygen and the nutrients necessary for the cells to undergo them metabolic activity.
Okay.
Yeah. So
So it's gonna-
you get vasodilatation. You get systemic. So if let's say if you're hypothyroid, if you've got too much thyroxine, your basal metabolic rate is high. All your tissues are using up oxygen like crazy. Yeah. So
So you increase blood flow.
Exactly. And what causes that increase? What causes that increased blood flow? What causes that systemic vasodilatation? Why is it that your arterioles dilate? What is the factor that allows for the relaxation of the smooth muscle in the arterioles? So what do cells produce? What do cells produce when they're metabolizing a lot of material?
Is that someone in the background, or is that?
That's my mum. Yes, she's being recorded. At least it's in a different language.
If there's not enough oxygen, they're going to be producing lactate and things like that. But
yes, lactate may be. You may be producing a bit of lactate, but you're producing a lot of carbon dioxide.
Yeah.
And with that, you're producing a lot of H plus. Yeah, H plus, carbon dioxide, other metabolic waste products. They all affect the arteriole, smooth muscle, and cause the arteriole, smooth muscle to relax. The lack of oxygen does the same thing.
Yep.
Okay, so if you have systemic vasodilatation, you've got a low afterload on the heart. Okay, so we talked about systemic vasodilatation. Okay, so vasodilatation. Now, similarly, if you go to the heart, okay, now normally I'm going to make the heart green for some reason. Now what happens at the level of the heart? You say the heart rate's increased, and that's for a number of reasons. But one of the things that thyroxine does is it increases the sensitivity of peripheral tissues to adrenaline. You know the beta 1 receptors?
Yep.
Beta receptors are highly sensitized when thyroxine acts on it.
Yep.
So it doesn't increase sympathetic drive as such, but it increases the sensitivity of the heart to noradrenaline.
Okay, yeah.
Which means that your heart rate, your heart will be more sympathetically stimulated. Okay, with me so far?
Yep.
Yeah. So sensitivity rises. So the peripheral tissues are more sensitive to beta receptor stimulation. So we have a few things. So beta 1 receptors are found in the sinoatrial node, increasing your heart rate. Where else in the heart do you find beta 1 receptors?
You find them in the ventricular and atrial myocardial cells.
Yep, yeah, you find them in the myocardium, in the myocytes. So when you perform beta receptor stimulation in the myocardium, you increase the contractility of the heart. Okay, you increase the contractility of the heart. So in other words, the heart will pump. The heart will have a greater. So a few things. The heart has a greater contractility. You have a higher heart rate because the sinoatrial node is firing away like crazy, and you've got systemic vasodilatation. All of these factors will increase the cardiac output.
Yep.
Your blood pressure won't change very much because you've got a very high. Your total peripheral resistance will drop. Your cardiac output will rise like crazy. Your blood pressure won't change very much generally because it's got a very strong negative feedback system. It's got a very strong regulatory system by means of the baroreceptor reflex.
Yeah.
But the fact that you've got systemic vasodilatation means that in a hypothyroid patient, you may see someone with a high pulse pressure.
Okay. Yeah.
Okay.
Yep.
You may see someone with a very high pulse pressure. So that's the effect of systemic vasodilatation. Okay, with me so far?
Yep.
Okay, so I've talked about the effects of beta of thyroxine on the cardiovascular system. Now, does this sort of make sense to you now?
Yeah.
Brilliant. Okay. So again, remember the term active hyperemia, yeah?
So if you were to have sort of a hyperthyroid state in a child, which I don't think is very common, because you don't have much ability to change your stroke volume, would that be more of an issue for cardiac compromise, do you think?
Oh, I'd have absolutely no idea. I haven't done PEET yet.
Okay.
PEET in my last rotation.
Good fun. Just remember that blood pressure has like no relevance, and you'll be good. Your pediatricians will love you.
So blood pressure has no relevance.
Well, because they can't increase their stroke volume, so they increase their heart rate. So their heart rate goes up, 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 up. And if their blood pressure's dropped, they're pretty much not coping. It's like the last mechanism to fall.
So in other words, the pediatric heart can't increase its contractility, is that what you're saying?
Yeah.
Because theoretically, if I were to give someone a lot of nitric oxide, surely the stroke volume would increase.
Not sure.
Anyways, that's another matter. Now, how are you with regulation? So I'll quickly take you through regulation of thyroid hormone secretion. So, we start with the hypothalamus, the pituitary, and the thyroid gland, yeah?
Yeah.
The hypothalamus secretes what?
It secretes like thyroid stimulating hormone, releasing hormone or something ridiculous.
Thyrotropin releasing hormone.
Yeah.
Yeah, thyrotropin releasing hormone.
Mm-hmm.
And then the pituitary, which pituitary? The anterior or the posterior?
Anterior.
Damn, I just wrote it. Which two hormones are secreted by the posterior pituitary?
The sex hormone.
Which one?
They produce.
One of them is involved in women's health.
Yeah, they produce the sex hormones, don't they?
That's still anterior pituitary. The anterior pituitary.
Okay. It's like oxytocin and
the other one is
antidiuretic hormone.
Antidiuretic hormone. Good, yeah. Antidiuretic hormone and oxytocin are secreted by the posterior pituitary. So the anterior pituitary secretes thyroid stimulating hormone. Now, thyroid stimulating hormone has a number of effects on the thyroid gland. Okay. Not only does TSH increase the secretion and the production and release of thyroxine by increasing the sequestration of iodine, increasing the release of thyroglobulin into the colloid, increasing the activity of the thyroid peroxidase, increasing the endocytosis of the modified protein, blah blah blah. Yeah, so the thyroid stimulating hormone has an effect on practically every single step of the production of thyroxine. You remember that little drawing we did earlier?
Yeah.
Yeah, so TSH upregulates everything. But on top of that, TSH is also a growth factor. It causes hyperplasia of your thyroid gland.
Mm-hmm.
Yeah? So stimulation of the TSH receptor causes hyperplasia of your thyroid gland.
Yeah.
Now, on this, so that's what TSH does, right? And that's the main aspect of the TSH. Now, that's normal thyroid function. Now we're going to talk about hyperthyroidism. Okay?
Yeah.
Right. So this is year 3 material. Yeah?
Yeah.
Okay. Now hypothyroidism, okay, so year 3B. So hypothyroidism, let's take us through some causes. What are the main causes of hypothyroidism?
Hyperthyroidism.
Yeah.
You've got
I apologize for the stairs, sorry. So give me 3 main causes of hypothyroidism.
Graves' disease.
Yeah, Graves' disease, that's a big one. Like most causes of hypothyroidism are Graves' disease. Good, Graves' disease is a massive one. What are the others? What are some others?
You've got you can have tumors, but
Good, tumors. What sort of tumors?
thyroid adenomas cause them.
Yeah. So what kind of thyroid adenomas are there? There's 2 main types of thyroid adenomas.
Now you're testing me. Not sure.
Toxic multinodular goiter.
Oh, yeah.
Yep, toxic. Yep. So we've got Graves' disease. Okay. And what is Graves' disease? What exactly?
Anti-thyroid hormone, anti-thyroid antibodies that are actually attaching to the TSH receptors, which then screws up the feedback system.
Yeah, because basically in Graves' disease, the antibodies produced usurp the function of TSH. They're TSH stimulating antibodies.
Yep.
Yeah?
Yep.
Then you have toxic multinodular goiter. And then you have the solitary toxic adenoma.
Mm-hmm.
Those are the tumors we were talking about, yeah?
Yeah.
Now, keep in mind, they're usually benign tumors that cause hypothyroidism, because if they're malignant, they wouldn't be functioning properly, would they?
No.
Okay. And then there are some other types. So thyroiditis, generally thyroiditis is biphasic. So the acute phase of thyroiditis, your thyroid gland, an inflamed thyroid gland, basically dumps all the thyroxine that it has in its stores, yeah?
Mm-hmm.
And then over months when it's depleted its thyroid stores, it doesn't produce more thyroxine, and then it becomes hypothyroid, yeah?
Yeah.
So in the early stages of a subacute thyroiditis or postpartum thyroiditis, you can get hypothyroidism.
Yeah.
In fact, in very rare cases, even Hashimoto's can give you, at the initial stage, a hypothyroidism. The term is hashitoxicosis.
Oh. Yeah.
Yeah. So the subacute phase of thyroiditis can cause a transient, temporary hypothyroidism. Here's another cause. Think of let's give you a Monash question. A 22-year-old gymnast. A 22-year-old gymnast presents to you with tremor, palpitations, sweating. You test her thyroid function, and she's got a low TSH and a high T4. You check her. You can barely feel her thyroid.
You can barely feel her thyroid, and she's got a high T4 with a low TSH.
Yeah, she's a 22-year-old gymnast.
Is she giving herself thyroxine?
Yep, that's good. Excellent. Factitious hypothyroidism.
Yeah.
You call it factitious hypothyroidism. Yeah. When she's taking thyroxine tablets. Lithium? Lithium can also cause hypothyroidism.
Okay.
Amiodarone can also cause hypothyroidism.
Mm-hmm.
Then there are other causes, like random causes. Like, have you heard of the term called struma ovarii?
No.
Okay. Struma ovarii is a phenomenon whereby there's a benign ovarian tumor.
Yeah.
And some benign ovarian tumors are like teratomas. We call them dermoid cysts. Yeah? They're teratomas. And because the germ cells, they can differentiate into any type of cell in the body, including thyroid cells, which produce thyroxine.
Uh-huh.
It's not common though.
Yeah.
It's not very common in the slightest. Okay. So
you have a low TSH, and then you're just having just the thyroid is producing it, but it's somewhere else in the body. So
ectopic thyroxine production. Yeah.
Yeah. So you're not going to have. Yeah.
So struma ovarii. There's also so you can have a pituitary tumor that secretes TSH. So a TSHoma, rare. And a follicular carcinoma of the thyroid can also theoretically be a functioning one and release thyroxine.
Mm-hmm.
Okay, with me so far?
Mm-hmm.
Okay, now moving on. Okay, so those are the different causes of hypothyroidism. Now, let's have a bit of fun and actually draw. And let's actually draw Mr. Hypothyroid, yeah?
Yep.
Okay, Mr. Hyperthyroid. Now, please forgive me for my drawings.
Okay.
Okay. Sorry, I apologize for that.
That's okay.
Yeah, just my parents. All right. Like my drawings?
Yeah.
Okay. So.
Looks like it.
Okay. So. Okay, hold on. Okay. Try my best to draw a goiter if I can. Hold on. Draw that in. Like I'll explain to you what I'm drawing later on. Okay.
I'm going to go with exophthalmos, goiter.
Yep.
Weight loss and loss of muscle tone.
You're too good. Too good. Too good. Okay. And a bit of. But hey, they say. Did you come to my cardio lecture?
No.
No. But I remember saying, like in the cardio lecture, pictures 1,000 words. I can give you a list of, clinical findings you see in hypothyroidism, but it's so much easier to remember if you just remember a picture.
Mm-hmm.
All right. So meet Mr. Hyperthyroid. He's a rather anxious character. Okay, he's a rather anxious character with pretty, with racing thoughts and the like. Yeah. He's anxious. He's a bit irritable. Can be a bit manic at times. Follow?
Yeah.
Okay. So in first and second year, we always get taught to examine from the hands.
Mm-hmm.
Yeah. General appearance. Actually, what would you see in vital signs?
Vital signs, you're probably going to see an increased heart rate, normal blood pressure.
Yep. With a high pulse pressure. High pulse pressure, remember?
Yep. Increased
Something like that. Yeah.
temperature.
Temperature, you may have
Does
a
it
slight
happen?
increase in temperature if you have a thyroid storm. So you become febrile. Yeah.
Yeah.
And your respiratory rate, well, who cares about your respiratory rate? Don't tell a respiratory physician that they'll eat me for lunch.
Yeah.
Okay. Tell me what you see on the hands.
So you can get clubbing?
Yeah, so it's actually an unusual clubbing. It's not the clubbing that you see in liver and in lung disease, yeah, or in cyanotic heart disease. It's an unusual kind of clubbing called thyroid acropathy.
Okay.
Right, actually, let me just draw the bone here. So, okay, thyroid acropathy. Okay, thyroid acropathy, and with that comes onycholysis.
Yeah.
These aren't common. These are rather rare. Okay, so thyroid acropathy and onycholysis. So basically, nail changes. Yeah, nail changes with acropathy. What else will you see?
Tremor.
Remember, tremor. So it's a fine tremor. So you won't see the tremor until you put a piece of paper. So this hand's hypermetabolic. It's got tremor. What else will it have? Hypermetabolic hand.
Red, flushed, hot.
Red, flush, and hot. Yeah, it'll be warm. It'll be sweaty. You'll have palmar erythema. Why do you get palmar erythema? Hint: hyperdynamic circulation, vasodilatation, systemic vasodilatation. Yeah.
Yeah.
With me so far?
Yeah.
Yeah. In fact, liver palms.
If there was another cause.
Yeah, liver palms, right?
Yeah.
Liver palms, like palmar erythema and liver disease. That's likely because you have too much estrogen in your body. Yeah.
Yeah.
And therefore, estrogen is a systemic vasodilator as well.
Oh, okay.
Yeah, it upregulates nitric oxide production in your arterioles from memory.
Okay.
Yeah, so you get sweaty, red, hot palms. Yeah.
Mhm.
Yeah, sweaty, red, hot palms. So onycholysis, clubbing, palm erythema, and sweaty. Sweaty and fine tremor. Yeah.
Yep.
Okay. Brilliant. What am I trying to depict here?
I'm not sure whether you're trying to say proximal muscle weakness, like in
proximal myopathy. Good. Yeah, proximal myopathy. That's what I'm trying to depict here. Good. Okay. What about the eyes are now the eyes are pretty obvious. What am I trying to say?
Exophthalmos lid retraction.
Yeah, so lid retraction, lid like exophthalmos, chemiosis. Okay. Now here's my next question. What sort of hypothyroidism do you get the really massive staring eyes?
Graves.
Why specifically Graves? You're right, but why specifically Graves?
No idea.
Okay, so you know that TSH receptor antibody, the TSH stimulating antibody that Graves produces?
Yeah.
It turns out that it also causes hyperplasia of your periorbital, orbital fat.
Ah.
You know the orbital fat surrounding your eye?
Yeah, yeah.
It surrounds all your eye muscles and your nerves, the ophthalmic nerve, the optic nerve and all that fat, the intraorbital fat.
Yeah.
That undergoes hyperplasia. So you get a collection of material around your fat and it pushes your eyes out.
Yeah.
And not only does it push your eyes out, it stuffs up your nerves.
Yeah, because it's creating tension on them, I guess.
Exactly. Which is why you get diplopia, which is why you get weakness of eye movements sometimes. What other disease causes a similar clinical picture? What other disease causes basically a buildup of tissue, a buildup of stuff in your orbital fat?
Not sure.
Orbital cellulitis?
Ah, okay, yeah.
Have you seen orbital cellulitis in a picture or anywhere?
I haven't actually seen it in real life yet. No.
No, but you've seen a picture of it, yeah?
Yeah.
And have you noticed it looks so similar to thyroid eye disease?
Not until now, but
it makes sense, yeah? They get exophthalmos. They also get diplopia. Sometimes they can get diplopia. Sometimes they get weakness of eye movements. Same pathology. Exactly the same pathology, except you've got a freaking infection going on inside your orbital fat. Which is nasty because if you have an infection down there, goes into your cavernous sinus, down your greater petrosal sinus, into your jugular vein, and next minute you got sepsis.
Yep.
And then you're stuffed.
Not a good idea.
Yeah, which is why, if someone's got orbital cellulitis, you transport them straight to hospital as fast as possible.
Yep.
Yeah. Okay. So let's start. What was that, sorry?
Probably preferably not the hospital I am currently at.
You're being recorded.
As in, preferably not a rural hospital.
You're being recorded,
No, but they send super sick patients on.
Oh yeah, too,
we don't have an intensive care unit.
Oh yeah, you send those patients off to the eye and ear.
Yeah.
Okay. What am I trying to draw here? Okay, perhaps it shouldn't be red.
Redness?
Nah, it shouldn't be red. I was trying to talk about periorbital edema.
Oh, edema, yep.
Yeah, and it's an unusual type of edema. It's mixed edema. It's not like pitting edema.
Yeah.
Basically, it causes your peripheral tissues. It causes your peripheral tissues, your fibroblasts. This is thyroxine. Thyroxine causes your fibroblasts and the like to produce mucopolysaccharide. So you actually get deposits of stuff in your interstitium, which is why you can get these weird you can get this weird edema, periorbital edema sometimes, yeah? Okay. So we've talked about the thyroid eye disease, and obviously you have your goiter, yeah? In what kind of hypothyroidism will you get a goiter?
Graves' disease, you get a goiter.
Yeah, good. In Graves' disease, you get a goiter. How about if you were to have a TMNG, a toxin multinodular goiter, that would be because your thyroid gland is producing, it's growing neoplasm. So of course you'd get a goiter. If it's a solitary toxic adenoma, the same thing would happen. What if you're taking factitious thyroxine? You were just sneaking thyroxine pills into your body. What would happen? Would you have a goiter?
No.
Your thyroid will get
It's
smaller.
the TSH that causes the hyperplasia,
Exactly.
and you're not getting the TSH.
Exactly. Okay. Nice. So we've talked about the heart stuff. So you can get, palpitations. You may also get. Okay, I'll give you a clinical scenario. You're in a hospital. A 35-year-old guy. 35-year-old guy is hypothyroid. He's febrile. He's very anxious. He looks like he's having the world's worst panic attack. You check his temperature. He's got a fever. You check his heart rate is like 160. His blood pressure is falling. You basically, and then you check his thyroid levels, and it's like through the roof.
So you're trying to imply a thyroid storm.
A thyroid storm. He's got a thyroid storm, yeah? His fever, he's tacky, it's really bad. And then you hear an S3 on your heart. Why would you hear an S3? You hear an S3 in your heart.
Cardiac outpoint, but
have you heard of high output cardiac failure?
Yeah.
Yeah, high output cardiac failure.
Yeah.
The older patients. So what happens with those people is because you've got systemic vasodilatation, and your tissues are so vasodilated, so you have a massive venous return into your right atrium and your right ventricle.
Yeah.
So your heart is chock-a-block full of blood. When your heart is chock-a-block full of blood, it stretches out. When it stretches out, it loses its function. It doesn't work as well.
Yeah.
And we call it high output cardiac failure. It just dilates. It undergoes eccentric hypertrophy.
Yep.
And then obviously, you get weight loss. Now, tell me what happens to your bowel function, and in a woman, what happens to her periods?
So periods increase. You can get menorrhagia, and you can get irregularity.
You get abnormal periods. Often we say
you can get both, can't you?
You can get both. So my understanding is the general term we often say is amenorrhea. But you can imagine that if you're amenorrheic for a while, and you'd be undergoing endometrial hyperplasia because your endometrium is just proliferating away, yeah? Say there's some sort of breakthrough ovulation and progesterone, you start, you've ovulated, and then that massive tissue, the amount of tissue that you've gotten through months or no periods, and then you get a massive bleed, menorrhagia. Which is why people with PCOS, they get periods of no periods, and when they do have a period, it's very heavy.
Yep.
Yeah, because they haven't ovulated in such a long time.
Yeah.
Do you get diarrhea or constipation?
Usually diarrhea, isn't it?
Diarrhea. Yeah, hypothyroid. Remember, everything's working like crazy. You get diarrhea. Yeah. What happens to your reflexes?
Hyperreflexia.
Hyperreflexia. What do you expect to see on your legs? Let's say someone's got Graves. What kind of finding can you see on the shins?
No idea.
Pretibial myxedema?
Oh, yeah.
Pretibial myxedema, yeah?
Yep.
Okay. All right. So say hello to Mr. Hyperthyroid.
Hello, Mr. Hyperthyroid.
What is that?
Hello, Mr. Hyperthyroid.
Yeah, he says hi back. I can't exactly get him to wave.
Not good enough.
Oh. Do you have any questions?
No. Okay.
So that's Mr. Hyperthyroid. Now, so you can imagine what a thyroid storm would look like. The guy's febrile, tachycardic, output cardiac failure, very anxious, crazy tremor. And then, this guy you have to basically stop. Have you heard of, you basically have to somehow arrest thyroxine metabolism, yeah?
Yeah.
So you give this guy lots of propranolol to stop the sympathetic sequelae of hypothyroidism, yeah? You give him propranolol. You give them propranolol. You give them. Have you heard of Lugol's iodine?
No.
Lugol's iodine is also known as sodium iodate. Okay, Lugol's iodine. And what Lugol's iodine does is that Lugol's iodine inhibits the peripheral metabolism of T4 to T3. So although you've got a lot of T4 out there, which is bound, it stops it from being converted to T3. So in the very acute phase, you give propranolol. You also give Lugol's iodine to try to stop getting the extra T3, and you give carbimazole to stop the production of extra thyroxine.
Yep.
With me so far? And then you need to give supportive care, so fluid balance, electrolyte balance, basics.
Yep.
Okay, how does that sound?
Yep.
Brilliant. So that's Mr. Hypothyroid. Now, I'm going to say hello to Mrs. Hypothyroid. Hypothyroid.
Yep.
Now, Mr. Hypothyroid, I should write, Mr. Hypothyroid has diarrhea. I can't give him no periods because he's a guy. So there's a kind of a bit of a problem there. Now, with Mrs. Hypothyroid, forgive me for my drawings. Hold on. Man, she looks more like she's got Cushing's. Okay, hold on.
It's very curvy.
That is not. Hold on.
I know what you're trying to say.
Yeah. Okay. Actually, you think she's curvy, huh? Okay, that's better.
Yeah.
Okay, that looks a bit more like Mrs. Hypothyroid, yeah?
Yep.
Single strand of hair?
Yep.
Very thin? Let's draw her eyebrows. This lady's got her eyebrows done.
Less of outer third of the eyebrow.
Yeah. You saw that, didn't you?
Yep.
So yeah, that's your eyebrows, and then there's hold on, to draw the massive tongue. She's sticking her tongue out at you. Okay. And all right. So obviously now this is hypothyroid. What would you expect to see in her body habitus?
Large body habitus.
Large body habitus with a low appetite, yeah?
Yes, and she's probably wearing a million sets of clothes.
She finds it pretty difficult to keep off the weight.
Yeah.
Okay. And what do you expect for her vitals to be?
Heart rate slower, everything else normal.
Bradycardic, blood pressure normal to low, temperature low, temperature maybe 36, 35, 36-ish, yeah? Okay. So tell me what you see in her hands.
Hands, they're going to be cold and pale.
She's slow, she's sluggish. Not pale as such. But actually, yeah, a bit pale. Yeah, should be a bit pale. And dry.
No, that's hot and clammy. No. Yeah, I've forgotten the other nail change, the other hand changes.
Just in general, she's cold, she's pale, she's slow and sluggish. Her blood isn't going through her capillaries particularly well. She'd be a bit cyanotic, wouldn't she?
Yes.
Peripheral cyanosis. Yeah, she may have peripheral cyanosis. What's the other metabolic change that occurs in hypothyroidism? Okay, 60-year-old female, looks sluggish, looks a bit depressed, looks very dry, has that particular appearance that I'm showing you to an extent. You check her lipid profile, and her cholesterol's through the roof. You see where I'm getting at?
Menopause.
No, not menopause. The cholesterol through the roof.
Yeah. I don't know what you're getting at, no.
Okay. Hypothyroidism. So hypothyroidism is a secondary cause of hyperlipidemia.
Yeah, okay.
In fact, it's a common secondary cause of hyperlipidemia.
Mm-hmm.
So sometimes you may see some xanthomata.
Oh, yep, yep, yep.
Yeah, you see some xanthomata. Okay, so she's got cold, fatty hands, basically. Cold hands with deposits of fat. Oh, sorry, of lipid.
Mm-hmm.
Okay, she may have a bit of carpal tunnel
Mm-hmm.
because again, if she's hypothyroid, chances are she's remember. Sorry, did I say? Oh, I made a mistake. I apologize. I said earlier that thyroxine causes peripheral tissues to produce mucopolysaccharide. It wasn't. Sorry, that was TSH that does that. Sorry, TSH does that.
Okay.
Okay. So usually when you're hypothyroid, you've got a lot of TSH around, yeah?
Yep.
Yeah. So you can get a bit of hypothyroid, you can get a bit of tissue build up here, and you can get carpal tunnel syndrome. And then if you go to the eyes, if you look at her eyes, she's got very thin hair, very dry skin, loss of the outer third of the eyebrow. With me so far?
Yeah, yeah.
Yeah. What am I trying to draw? What am I trying to depict here?
Coarse tongue.
Not coarse. Okay, let me make it a bit more obvious.
Oh, I can't remember what it is.
Still not obvious enough to you?
Large. But we said that before.
Yeah. Did you say large? I didn't hear you say that.
No, you said that before when you drew it.
Oh,
I was
yeah.
like,
Is that large enough for you?
that is certainly large enough for me. I might start mistaking it for a baby bib.
Oh, God. Yeah. So why is it that she has a very large tongue?
No idea.
Myxedema again. Myxedema,
Okay.
myxedema. Yeah?
Myxedema.
What
Yep.
other endocrine condition gives you a massive tongue? Excess of which other hormone can give you a massive tongue?
Can that be like the growth tissue, the growth hormone, and you get that in
Very good. Growth hormone.
acromegaly?
Yeah, acromegaly. Yeah, good. Acromegaly. Growth hormone excess can also give you a ginormous tongue, yeah? You can obviously, okay, good. So you can obviously, now let's put her tongue back in her mouth. And we're having a lot of fun, aren't we?
This is great fun. Anybody listening is gonna think that I'm a weirdo, but
Oh, dude, they're going to think I'm a weirdo. I don't care at all. Songs that teaches them. I'm weirded about it. Good. So you obviously have a bit of a goiter, just a bit, just a bit. And on top of that, you percuss the lungs and you feel stony dullness. You percuss the lungs and you feel stony dullness.
So you've got a pleural effusion.
Yeah, pleural effusion. You can also get a pericardial effusion on top of that, actually.
What's the mechanism for pleural effusions?
Honestly, I'm assuming it's got something to do with the myxedema, but I'm not entirely sure. I don't want to give you a false answer.
That's fine.
Oh, I forgot. You may get a bit of xanthelasma here as well.
Yep.
Because you're hyperlipidemic, yeah?
Yeah.
Okay. Going to the abdomen, nothing very much. You get constipated, you get menorrhagia. Cool?
Yep.
Yep. Constipated, menorrhagia. And what happens to your legs? So you see that you look at her ankles and they're swollen. Both her ankles are swollen, and you say that lady's got bilateral edema of her lower limbs. When you press your fingers on her legs, what do you expect to find?
So you're getting this to do with the myxedema again.
Good. Is it a pitting edema or a non-pitting edema?
I don't know. Let's go with pitting.
So pitting. Okay. Okay. Let's talk about someone with heart failure. Why does the patient with heart failure have pitting edema?
Pardon?
Why does the patient with heart failure have bilateral pitting edema of the ankles?
Fluid overload, and then it's the
Yeah, water retention.
Yeah.
Yeah, fluid retention.
Okay, so they're not getting pitting edema.
Yeah, these guys don't get pitting edema because it's not fluid that's been extravasated in a person with hypothyroidism. It's protein. It's mucopolysaccharide. Well, it's not protein. It's a carbohydrate. It's mucopolysaccharide that's been deposited in your peripheral tissues. So non-pitting,
enlarging, which is why your tongue gets big. Yeah.
Yeah, exactly. That's why your tongue also gets big in amyloidosis as well. Deposition diseases. Yeah.
Mhm.
Yeah, acromegaly, amyloidosis, myxedema, blah blah blah. Yeah.
Yeah.
Yeah. So bilateral non-pitting edema. Shit, I've drawn small legs on her. That's probably a bit inaccurate. What do you find when you test her reflexes?
Hyporeflexia.
Actually, it was sort of.
Oh, actually, do you get the normal? Are they just normal?
It's called a hung-up reflex.
Yeah.
Rather uncommon. It's if you're massively hypothyroid, you can get a hung-up reflex. Basically, you tap their shin. You tap their quadriceps tendon. They'll flex. So no, they'll extend. The muscle will contract, and then it'll slowly relax.
Okay.
Yeah, the leg goes up and then slowly down.
Right.
Hung up reflex. It hangs up for a while and then it goes down.
Yeah, so it's not like a clonus. It goes up and then down. It's not like a jerky thing at all.
No, it's not a jerking thing. So it stays up, remains tense, and then slowly but surely goes back to its normal position.
Yeah, sure.
Yeah, cool.
Yeah.
And that is Mrs. Hypothyroid. I may have missed a few signs, but I've got the main ones, yeah?
Yep.
Yeah. Do you get the picture?
You could draw in her uterus because she's a missus.
Huh?
You could draw in her uterus because she's a missus. But
yeah, the menorrhagia, yeah. Yeah. So that's the endometrium. And then lots and lots of stuff. Menorrhagia, yeah?
Yeah.
Okay, so Mrs. Hypothyroid and Mr. Hypothyroid.
Yep.
Yeah?
Yep.
Okay, brilliant. Oh, I didn't ask you about the cause of hypothyroidism.
Causes of hypothyroidism.
Yeah, what are the main causes of hypothyroidism?
So you can get sort of the end stages of the thyroiditis, so the Hashimoto's thyroiditis.
Hashimoto's, yeah, from the outset, the Hashimoto's thyroiditis generally causes hypothyroidism because remember the antibodies against thyroid peroxidase. It's like giving someone antithyroid drugs because it acts on the same enzyme.
Yeah.
Yeah. Okay. What else?
You can get the you can get an iron deficiency iodine deficiency can cause.
Yeah, iodine deficiency. So worldwide, it's the most common hypothyroidism. Yeah. What else?
Yeah, you can if you're giving too much antithyroid medications.
Yeah, good. Yeah, that's a good cause. Anything
potential
else?
That neoplasms can like take the place of healthy tissue, and then they can cause a.
That's a reasonable idea, and I would look that up. But good thought. How about a thyroidectomy?
Yeah, well, that causes it too.
Yeah. Graves' disease with TSH receptor blocking antibodies. How about that?
Does that exist?
Yeah, it does.
That's amazing.
Yeah, so mostly it's TSH receptor activating antibodies, but occasionally you can get Graves' disease where it's TSH receptor blocking antibodies, so you actually get hypothyroidism.
Yep.
Funny, isn't it?
Mm.
Yeah. Now, antithyroid agents, amiodarone and lithium, remember?
Yep.
They can cause hyperthyroidism, but they can also cause hypothyroidism as well.
Yep.
Okay. Now, I actually missed something. I knew I missed it. Why did I draw a bone there?
Is he gonna get? Is he gonna get a? getting an increase in protein turnover, but he's not getting an increase in bone turnover.
Oh, he does get an increase in bone turnover. Bone is partly calcium hydroxyapatite and part protein. Remember, that's why bone has good tensile strength. That's why if you were to bone and pull it, it doesn't break off into fragments because it's got the collagen, a lot of collagen.
Okay, so since you're getting mostly protein catabolism, can it cause a sort of osteoporotic picture?
Absolutely. Long-term hypothyroidism can cause osteoporosis, which is why if you have someone with thyroid cancer, right? If you have someone with thyroid cancer and you do a thyroidectomy, you know how you give them suppression thyroxine?
Pardon?
You give them suppression thyroxine.
Yeah.
Because you give them enough thyroxine to function, but you give them just a bit more so that the TSH levels go close to zero.
Yeah.
Because TSH is a growth factor as well. But you only can do that for like 5 years. You can only give suppression thyroxine for like 5 years-ish, and then we had to wean them off because if you give suppression thyroxine for too long, they'll get osteoporosis.
Okay, lovely.
Yeah, the increased bone turnover.
Yeah.
So, how does that sound?
Good.
Good. So, do you feel a bit better about it?
Yeah.
That's good.
Good revision, and it's good to actually go through the mechanisms because I kind of just rote learnt them.
Yeah, don't worry. Like I hate rote learning. I can't do it to save my life, which is why I have to go all the way to actually know them. Try to understand the mechanism so long as it takes.
To any year 1 and 2s listening, don't rote learn. It doesn't do you well in the end.
Okay, how does thyroid function change in pregnancy?
You can get. I know.
What happens to TSH in the early stages of pregnancy?
You get increased. You get a hypothyroidism is more common, isn't it?
Okay, that's in a disease state. So sometimes you can get Graves' disease during pregnancy. That can sometimes happen. I'm talking about in a normal, healthy woman who's pregnant. What happens to her thyroid function? What happens to her TSH level?
I'm not sure. I should know this.
No, it's okay. I'll give you a hint. So this is TSH. You know TSH is a peptide. It's a peptide hormone, yeah?
Yeah.
And it contains an alpha and a beta subunit.
Mm-hmm.
And similarly, another hormone called HCG also has an alpha and a beta subunit, yeah?
Right.
And TSH and HCG and, in fact, LH. You know LH also has an alpha and a beta subunit?
Yeah.
It turns out that the alpha subunits of these 3 hormones are the exact same and the beta subunits are very different.
Yeah.
Have you noticed that we actually look for a beta HCG when we look do a pregnancy test? It's because the beta subunit is specific to HCG. These 3 are different for these 3 hormones, whereas the alpha subunit is exactly the same. In fact, HCG and TSH cross-react. If you, in a pregnant woman, she produces HCG, human chorionic gonadotrophin. So above the placenta, the trophoblast, anyway. And that HCG actually acts like TSH.
Yep.
So therefore, it causes the thyroid gland to produce more thyroxine. The extra thyroxine inhibits TSH production. Your TSH levels drop precipitously.
Okay.
Yeah, TSH levels drop during pregnancy because of that HCG.
Yep. And
correlating that with LH, you know how in a woman who you want to stimulate her ovaries to ovulate, yes, in a person who's undergone fertility treatment?
Yep.
You know you can give LH, theoretically, you can give LH, yeah?
Mm-hmm.
Lots of LH to cause ovulation. In fact, we give HCG instead.
That's slightly. I feel like if people take a pregnancy test at the wrong time of the month, they're going to get their hopes up a little bit too much.
No, well, for starters, we only check for beta HCG, remember? That's why we check for beta HCG, so we don't mix it up with LH and TSH.
Yeah.
Yeah. But yeah, I like your thoughts. Yeah, so in pregnancy, what are some other considerations of thyroid problems in pregnancy? You also want to make sure that the woman's euthyroid in pregnancy, because hypothyroidism in the early stages of pregnancy is associated with a high miscarriage rate and pregnancy loss. Additionally, if you're profoundly hypothyroid and your kid is born, and this kid is also hypothyroid, that's right. I'll take back the last thing I said. But hypothyroidism in the kid can cause, do you remember cretinism?
Yeah.
Yeah, I need to look that up myself actually. So, okay, so what are the drugs? So say a woman's got Graves' disease and she's been treated with carbimazole or propylthiouracil and she gets pregnant. What do you do then?
Go and look up their pregnancy classification.
So you have to reconsider whether you want to keep them on antithyroid drugs, yeah?
Yeah, but usually you're gonna have to keep them on something.
Yeah, you have to give them on something. So that's why, from my understanding, and don't quote me on this, from my understanding, I think you want to lower the dose of the drug as much as possible whilst not rendering the person hypothyroid.
Yeah.
Yeah. So propylthiouracil, like carbimazole, can be teratogenic, from my understanding. Keep that. Just check it out. And propylthiouracil you can't just say a drug is safe in pregnancy or a drug is not safe in pregnancy. Like carbimazole and propylthiouracil are a bit dodgy in pregnancy. So you want to review the dose of the drug, from my understanding. But if you want more complete information, we just have to have a look at the clinical guidelines in the Royal Windows.
Yeah.
Oh, that's okay. So that sounds good. Any questions, Shelley?
No.
No?
Nope.
Okay. No, that was a fun tute.
That was really good. I will
good.
go back and listen to your other tutes.
Oh, cheers! Yeah, the others are cardiology tutes. Yeah.
It can't hurt.
Yeah. So for everyone listening, so remember, a picture is 1,000 words. This is Mrs. Hypothyroid, big, bloated, a bit depressed, slow, dry, thin hair, protein all over the shop, protein in the eyes. Oh, I forgot to say, you can also get periorbital edema and hypothyroidism as well. The protein around the eye, protein in the legs, protein around here causing carpal tunnel syndrome. With me so far? And similarly, Mr. Hypothyroidism, who looks like he's X-raying you whenever he looks at you.
I like it.
Yeah, actually, his mouth should be open because he's anxious. And his hair is sticking on end because he's like scared. Okay. All right. So we'll leave it there. And so I hope you enjoyed the tute. I hope that you learned a lot out of it. If you have any questions, you can always either comment on the YouTube chat on the YouTube commentary box, the comments, or just message me on Facebook if you have me on Facebook. All right, we'll leave it there. Thank you very much, and thank you and good night.